So welcome everyone. My name is Corey Lubring, and I'm the PBRN coordinator at DO-Touch.NET. Thank you for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, let us take a moment to cover the housekeeping rules again for the webinar. First off, please feel free to introduce yourself in the chat and tell us where you are from. We also invite everyone to turn their cameras on so we can be united as an OMM research community. Second, if you have any technical issues during the webinar, please put a message in the chat. Third, if you have any questions or comments during the presentation, please feel free to type them into the chat and address each other's questions and comments there as well. We will also have time for discussion and questions at the end of the presentation. And lastly, please keep in mind that this webinar is being recorded and will be placed on the public DO-Touch.NET YouTube channel. And today is our Let's Talk About OMM Research educational webinar entitled, What Am I Palpating? Trying to Determine the Nature of Abnormal Paraspinal Tissue Texture with Dr. Gary Fryer. And for his introduction, I'm going to pass it over to Dr. Degenhart.
Thank you, Mr. Lubring. Appreciate it. And thank you, Dr. Fryer, for joining us today. So Gary Fryer is the associate professor and course chair, which is kind of like a dean in the United States of the osteopathic program at Victoria University in Melbourne, Australia. Gary completed his osteopathic training in 1990 and his PhD, I believe, in neuroscience in 2007. He has practiced osteopathy in Melbourne, Brisbane, and in rural sites throughout the state of Victoria in southern Australia. He is a great majority of Gary's career has been at Victoria University in Melbourne, which is the second largest city in Australia. Since 1997, he has been extensively involved in osteopathic education and research at the university, teaching osteopathic principles, techniques, and research methods. For over a decade, he has also filled various leadership, administrative, and coordinator roles at the university. As a researcher and educator, Gary has been an advocate of evidence-informed approach to teaching and practicing osteopathy. In other words, in my words, Gary can be quite critical of osteopathic models that are taught in practice as truth, but is based on no or refuted evidence. As a result, Gary can be challenging to the status quo of modern osteopathy, and I suspect he will be no different today in some of his comments. After completing his PhD in 2007, Gary joined the Research Institute here in Kirksville, Missouri, for a 2-year intensive research postdoc where he had access to modern instrumentation and techniques to reevaluate classic osteopathic methodologies, which were developed by Stead Denslow and Irvin Cora here at Kirksville in the 1940s. Then, after returning to Australia, he has continued to collaborate with the Institute for years and continuing to advance the science of osteopathy. So throughout his career, his research interests have been very diverse, assessing the reliability of palpation, the use of osteopathic techniques by international profession, the biomechanical effects of spinal manipulation, and the neurophysiologic mechanisms of manipulative treatment. Now, I wanted to share, through his work, he has authored over 60 articles in peer-reviewed journals. He has many book chapters that he's been published and has been an invited speaker in osteopathic conferences in Australia, United States, United Kingdom, Europe, Korea, Brazil, Spain, and others. So I wanted to share, just as a kind of a blast to the past, a picture that was taken when Dr. Fryer left us here in Kirksville. And here we see him with Christian Fossum, who was also here at the time, standing in the shadow of the tombstone of Arthur Hildreth, who wrote the book, the shadow, the extending shadow of A.T. Still. And at that time, in our early careers, we thought, well, wouldn't it be great to stand in that shadow, and how, how our future may result with our work in the profession. And I can say without a doubt, Gary has significantly extended the shadow of Andrew Taylor Still, as was written in that book in 1942. So it is a great honor for me today to introduce to everyone within DO-Touch.NET the ageless Gary Fryer. As you can tell, he looks no different from the picture that he had taken back in 09 or thereabouts. And we are honored to hear about his work in today's webinar. And so thank you for getting up particularly early in Melbourne to join us today. Thanks, Gary.
Thank you very much, Brian. Thank you for that wonderful introduction. And I'd forgotten all about that photo of the lengthening shadow of Hildreth with myself and Christian there. It sort of brings back wonderful memories. And I'd like to thank the DO-Touch for this invitation. It's a real honour to be asked to come and talk about my research and to talk to you all. I'm going to share my screen now, and hopefully I'm working on a brand new computer, so hopefully it all goes seamlessly. There, and oops. Okay, hopefully that is visible to all, and could I get just a verbal acknowledgement, because I can't see you at the moment.
Why am I? It's not yet seen.
That's a yes?
It's not
No.
sharing.
It's not sharing. Oh, okay. Okay. That's interesting.
There you go.
Okay, I will just move my... Okay, great. And that's full screen, my
Yep, looks good.
It looks good. Okay, fabulous, fabulous. I suspect I'll just move that there. Great. Okay, as you can see from the title, what am I palpating? Particularly well, even as a student and then early career as an osteopath, it struck me, like it probably strikes everybody, that when we palpate the tissues of our patients, and particularly for me, I was interested in the paraspinal area, I'd often run my hands down somebody's back while they were lying prone and quickly find a spot that appeared abnormal to palpation. And very often, the patient would say, "Oh yeah, you've got the spot straight away." We've all had this experience and continue to have this experience where our hands, it can easily locate those areas that feel abnormal to a patient and feel abnormal to us. But the more I looked into this, and particularly as a new teacher, sort of back in the late 90s, I sort of realised that we didn't have a clear understanding of what exactly these tissues were and what they represented. There were many theories, and in the osteopathic profession, we particularly looked towards the work of Denslow and then later Core, as to explain what this was, but there hadn't been a lot of research on those, on exactly, what these palpable structures were, since. And there were lots of theories, which I'll mention briefly later, but about potentially muscle spasm, abnormal muscles contracting, and even other things such as tissue fluid, but there didn't seem to be any real clear consensus. Excuse me, I'm just going to have to... there we go. So we're all familiar with the concept of somatic dysfunction and the clinical signs of somatic dysfunction. Now, this does vary from author to author and text to text, but essentially, most commonly, we have this acronym or TART: tissue texture abnormality, asymmetry, range of motion change, and tenderness. Some authors also include sensitivity and pain provocation, call it either STAR or START. What I'm going to focus on is the T part for tissue texture abnormality. However, as mentioned, the actual pathophysiology of the tissue texture abnormality and really somatic dysfunction itself was still, very largely speculative. When we look at the human hand and what we are able to palpate, we know that the human hand is an extremely sensitive organ, and it suggests that we're really good at palpation and we should be really accurate and really reliable. Yet somewhat disappointingly, when we look at the studies for the reliability of palpation, and there are a lot, we see, look, we've got, fair to acceptable inter-examiner reliability for things like gross range of motion and tenderness or pain provocation. We're pretty good at finding the sore spot and agreeing with another practitioner about that. But when we come to things like static asymmetry of landmarks, segmental range of motion, tissue, and even tissue texture changes without that tenderness, we don't seem to be very good. And study after study, there are some exceptions, tend to support that we don't tend to agree with other osteopaths or other practitioners who assess the same person. And this might be related to the fact that it's complex. It's complex activity, locating precisely tissues as they vary greatly, even just sort of slightly moving off the tissue area. And practitioners have idiosyncratic ways of non-standard ways of palpating. Dr. Brian Degenhardt is very well aware of this, and as probably most of you know, he's devoted many years to come up with models to try to improve our reliability for palpation of things like landmarks and motion segmentally. Given the poor reliability and unclear pathophysiology of somatic dysfunction, some researchers have therefore questioned whether it exists. When we say somatic dysfunction exists because we can palpate it with little other substantiating, objective data, and yet our palpation for it is not reliable, there is a question of, well, is this an independent entity or not? So the tissue texture abnormality, when we look at some of the historic research, particularly Denslow and Core, there's certainly suggestion that at rest these muscles, paraspinal muscles, are more active than normal, and perhaps that is what we are palpating when we palpate these paraspinal areas that feel different. Authors like Greenman and others have highlighted what they've called the very deep fourth layer muscle in the paravertebral gutter. So that's the groove between the prominence of the midline spinous process and the bulk of the more superficial erector spinae. And in that groove, it's a common area to palpate for segmental changes. Other authors have suggested, that osteopathic manipulative procedures also reduce this increased or this abnormal resting motor activity of paraspinal muscles too. But as we'll see, the evidence is a bit contradictory and inconclusive. As mentioned, Denslow and Core in the first report in 1941 reported spontaneous activity in lesion areas that were identified by palpation, by Denslow, as having the spontaneous activities where areas surrounding that area that appeared normal did not. This body of work in the 40s and 50s was truly pioneering, and their work is still quoted today, and it sort of shaped the concepts of profession. I think it's fair to say for well over 50 years, and probably still does. But there were limitations to the study. When we look closely at these early EMG studies, we see that often, particularly by today's standards, the methods weren't clearly described, and they sometimes said they did different methods between subjects. Sometimes our outcome criteria as what defined presence or absence of activity, what were the thresholds, were not clearly defined, and most of these papers didn't report or reported very little data, if all, and no statistical analysis. So they're very lacking by today's standards. When I first became interested in this, sort of at the around in the early 2000s, I sort of realised that there really hadn't been any substantial reinvestigation of these early studies. Even later in 1975, Denslow reported that the findings were inconsistent, and often by bolstering the subject with pillows and so on, this spontaneous activity sometimes disappeared. So it seemed to be some question about it, and as I say, hadn't been verified. So that from that, there were a number of questions. I thought, well, firstly, what tissues might actually be palpable in this paravertebral gutter, which, at least for me, was a very go-to area when palpating people for, assessing for, somatic dysfunction or spinal dysfunction, often in cases of, thoracic or low back pain. Are the areas that are identified as abnormal to palpation in this paravertebral gutter, well, firstly, are they more sensitive to palpation? It could be that these things, when we palpate something in the gutter and we sort of dig in there and they go, oh, you've got the spot. Maybe we're actually putting more pressure on it just because it feels different to us, and we're with our confirmation bias, we're pressing in harder, and that's why they're tender. And then, do these areas have abnormal motor activity, as evidenced principally by EMG, and motor activity at rest, during activity? Maybe they respond differently when we're moving around doing functional tasks, and maybe they respond differently to being treated, with osteopathic manipulative treatment. So the first question, well, what tissues might be palpable? A very basic, quick study just to get the ball rolling. We had access to cadavers, so we sort of palpated a spot and felt what was the paraspinal groove, a paravertebral groove in cadavers, and put a pin in, and sure enough, we went through a number of layers from the spinalis then to the semispinalis, and when we got deep, it as expected, we found it was right over the or sort of right in the area of the the transversospinalis group, particularly the rotatories. You can see the pin going through the rotatories brevis there. And if we actually took them away, the pin went right through the facet joint in the thoracic area. So it at least supported that, well, perhaps, the things that we feel in this sort of area, this groove, could potentially represent changes, be it in these deep layer muscles as proposed by Greenman and others, or maybe even in the around the facet joint itself. So the next question was, well, are these things actually more sensitive to palpation, or was it in fact palpatory illusion? To do this, initially I started off with a conventional algometer, which is just a handheld device, trying to locate these areas, but we found it wasn't reliable for this purpose. These spots needed to be palpated deeply, and when we palpated them and took the hands away and tried to use the algometer, we just weren't confident we're on the same spot. So I was able to adapt a particular pressure sensor that was mounted on the finger, as you can see there, which we sort of called the digital algometer. It was sort of based on something at the time called the palpometer, which is a sort of a similar device, but a different hardware and software. So it was a round pressure sensor, and the beauty of this is that it was small and soft, and it didn't interfere with palpation. So when palpating deep tissues, we could get a real-time measure of the amount of pressure used on the tissues. And the computer display wasn't in view of the person doing the palpating, so we made sure that source of bias was not present. And so in just one study, sort of had 26 participants. They were asymptomatic, or they had some of them had mild symptoms, but they all had a spot that was initially able to be located, a spot that appeared abnormal to palpation and appeared tender to them when asked. So they had one of these, what we call abnormal ABPT spots, so abnormal to palpation, and following identification with palpation on a request, they said it was tender. So it wasn't, it was identified primarily and initially with palpation, and it was then later confirmed as being tender, which reflects normal practice. And we had, a normal spot above and below and on the other side to compare with. We found the process was reliable with repeated measures, and sure enough, the abnormal spot was objectively more sensitive to pressure when we took the pressure pain threshold. Now, if you're unaware, the pressure pain threshold is the point at where, if you slowly increasing amount of pressure, it is the point that the participant says when the amount of pressure that takes for the sense of pressure to change, the first point to change to pain. And it's a commonly used measure. It's reliable, although it's still subjective. That point of changing from pressure to pain, it's a well-established, reliable measure, and a surrogate measure, if you like, of pain. So we knew these things were in fact more sensitive to pressure. It wasn't palpatory illusion. It wasn't because we were unconsciously pressing harder and firmer on the things that we thought were actually more tender. And this altered pressure sensitivity suggested that some type of pathophysiology does indeed exist. There is something going on here. So the next research question, well, do these abnormal sites display abnormal EMG activity? Firstly, at rest. So the surface EMG where we're putting surface electrodes on the skin, weren't really going to be very useful for this, because the tissues of interest here were deep, and there was going to just be too much crosstalk and lack of specificity with these surface electrodes. And the original studies that Denslow and then Denslow and Core did were with needle electrodes. So we firstly sort of examined whether needle electrodes were a likelihood, but they were rarely used in modern research, and the standard were these indwelling fine wire electrodes. And the advantage of these is they, once inserted, they were much smaller than needle electrodes, so likely to cause less tissue damage, and they were embedded in the muscles, which enabled ongoing transmission. And once embedded, they were generally painless, and often people could do their normal activities. So I initially did one study in Melbourne. I had to use the Melbourne University, a neighbouring university's equipment, and because we didn't have appropriate equipment. And without going into details of that study, initially it suggested, the data suggested that the abnormal site did actually have more activity, but on going back and analysing it later, we weren't confident with the measures because of there was electromagnetic contamination particularly at that middle channel, which was very disappointing. And although Melbourne University, we're the prestigious university in Melbourne, Australia, this particular equipment was fairly antiquated, and as we see, it was we had contamination, so we weren't confident of those results. Fortune favoured me, however, because I was very, very fortunate to be invited by Dr. Degenhardt to join the A.T. Still Research Institute and continue some of these investigations, among others, at the Research Institute for a period of 2 years, which was just a wonderful, amazing opportunity, and I'm so grateful for that time. And the first study that I did with EMG, we tried to replicate essentially that Melbourne study that we did, which was based off the original findings of Denslow and Clough in 1941, as well as that previous study. And we did publish this study, and I was pretty pleased to see the picture highlighted on that particular JAOA journal. So we got to use state-of-the-art equipment, the telemetry equipment, Noraxon gear. We've got to use better methods, where we came up with a method of EMG normalization, using a reliable method of maximal voluntary contraction, which in EMG is important to be able to compare between sites and between individuals, because there's so much individual variation, to express it as a percentage of their maximal. We had a greater sample size, 24 participants, and they were symptomatic. We thought, it was important. It represented more the type of patient that we would see, those who had current thoracic pain, at least a minimum of a 3.3 on a 10-point visual analog scale. So fine wire electrodes, as I say, we inserted them about 2 centimeters lateral to the midline SP. They were progressed in an anterior and slightly medial direction, right down until the resistance of the lamina. So we were sure that we were in that area. And we initially verified with diagnostic ultrasound that we were in the right location around those deep layer muscles, the rotatories and those deeper transverso spinalis. And then the wires get left in situ, and we also had a surface electrode on the other side. as well as a reference one. So we had either 3 centimeters, or if you're a big beefy bloke, you got the full 5 centimeter hypodermic needle with a fine wire threaded. So they were progressed. Now initially they were done by Dr. Robbins, who then trained me up to do some of these too. And I know what you're thinking. This enthusiastic but somewhat mad Australian putting needles into young healthy medical students, but it looks like it'd be painful, but it wasn't. I had this done to me myself, and generally what you do is you feel a sense of maybe a slight pricking sensation initially, a sense of pressure after that, and they're not painful, and the needle then is immediately removed, leaving these hair-like wires in situ. And the end of the wire is a little hook, so it's actually hooked into the target muscles. So we had the fine wires in this abnormal to palpation site, which we identified with 2 practitioners and consensus palpation. So we were confident this did appear abnormal to palpation, and 2 relative normal areas above and below that abnormal site. And then we had a surface electrode on the other side to compare to as well. And we did this under a number of tasks. Initially resting baseline, then we developed, and we, in a separate study, we looked at the reliability of maximal voluntary contraction task, which was isometric head and trunk extension, and we looked at doing it against resistance and doing it a free movement to get a reliable method, and then following another baseline period after that. So that's sort of producing that resistance to neck extension, which produced maximal activity from those mid and upper thoracic muscles. The results of this, however, were that there was no significant effect of sight. Disappointingly, seems to be the story of my research life. I'd hoped to, or sort of expected that we would find abnormal activity at that site, but using these methods, we did not. In either the first or second baseline period, there were no difference between that and the normal above and below. What we did find is that the EMG was highly variable, and between the sites within a person and between different individuals. So this suggested that the palpable paraspinal areas, the tissue texture change in those deep, or at least those deep muscle activity, were not abnormally active during resting motor tone. Interestingly, all of them were active to some extent, and some authorities say when muscles are at rest, they should be completely silent. We didn't find that. So, well, if they don't have abnormal activity at rest, what about during activity? Maybe functionally, the activity's increased. Now, I intended to look at how these things move when they're sitting up, when they're rotating, when they're bending forward, a number of functional tasks. I was also considering doing perturbations and seeing if they respond differently. However, my hopes and dreams were dashed, I'm afraid, there. Because we found that once we got our participants moving, the recordings weren't reliable. Although these were embedded in the deep muscles and the little wires were hooked, they started migrating as soon as our participants moved. And in some cases, even when they were doing the maximal voluntary contraction tasks, we would start to lose channels here and there. There were a couple of cases where they were resting, and in front of our eyes, we could see the wire slowly sort of moving out. And when we took the wires out, often they were zigzagged, they were kinked, and it's due to the fact that there are really high pressures in the muscle fascicles, in these deep muscles. You know, when these muscles are active, putting a lot of pressure on, and it's very easy then for them to move these indwelling electrodes. I also hoped to replicate one of Denslow's studies where we're applying pressure on the SPs of the vertebra to stimulate reflex activity, to look for low threshold areas. But again, because of the problems that we had with what I've then started calling the dark art of indwelling fine wire activity, we weren't able to do that. However, it was able to look, we were able to keep with the resting activity and wondered, well, do they change in response to OMT? Maybe that, there's not much, because of the variability within our people, there's not a difference between sites at rest. But if we perform some type of OMT, then maybe they actually respond with greater relaxation than surrounding sites. So we looked at another study, again, 22 participants with thoracic pain using the same methods as before, looking at a randomized crossover design where they came back for 3 testing sessions, 1 week apart, where we randomized one of 3 interventions, either a high velocity, and due to the nature of they had to be prone, so it was a cross-hand high velocity technique, a counter strain technique, and then a control technique, which is a sham laser. We had a laser therapy, and we showed them what it looked like and warned them that to tell us if it was burning, and it was being applied to the spot, but we didn't turn it on, and they didn't know. So it was a sham treatment. It was sort of a picture of the cross-hand high velocity technique, and a picture of one of the counter strain techniques. And this was published also in this case, the Journal of Bodywork and Movement Therapies, and also involved colleagues like Jane Johnson, Associate Professor Michael Bird from Truman, Barry Robbins, Dr. Barry Robbins, who is the osteopathic neurologist. In this case, again, we looked at different conditions. The baseline, we used a functional submaximal contraction task where they're just lifting up their head for 5 seconds as a surrogate of like a functional movement to see do these muscles behave differently in this movement. The maximal voluntary isometric contraction task for normalization, and then a baseline resting period after that. And in the end, we found for the counter strain condition, immediately following counter strain, there was a small, significant decrease in resting activity. It was small though. It was about less than 3.3% of, if you like, their maximal activity. For the other conditions, following the high velocity or the sham control, there were no significant changes. So this was interesting, but we had to question, is it clinically meaningful? It was a very small change, but not only that, it wasn't specific. It occurred in the baseline resting following the intervention, as well as there was a change in the extension activity or difference there, but it wasn't specific for site. All 3, the target area was the abnormal site, but all 3 indwelling sites reduced their activity. And it may just have been a result of putting that person in a very comfortable position for 90 seconds that produced a bit more general relaxation of all sides. So I question whether, you know, it was actually clinical meaningful or whether it was having any specific site on the target tissue. So yeah, that was, again, didn't come up with the results I thought I might. And it relates possibly to the fact there were many problems around the use of fine wire indwelling EMG in the deep paraspinal muscles. And I wondered, could there be other methods, maybe less invasive methods of determining changes in motor activity? On return to Victoria and Melbourne University, I started to explore other areas or other possible techniques. And I was lucky at that time to have a researcher, Alan Pearce, who was a real authority with some of the neurological testing, including H reflexes, where we directly stimulate a spinal nerve showing indicative changes of spinal motor neuron excitability, so the alpha motor neurons in the spinal cord, and also and he was an expert in motor evoked potentials stimulated by TMS, transcutaneous magnetic stimulation. And these are indicative of changes in central motor excitability, the motor cortex. So this could be another way, a less invasive way, maybe a more reliable way of doing that. So the TMS is used to evoke motor potentials involving a coil with a magnetic field placed over the motor part of the brain, the motor cortex, and measured by surface electrodes on a target muscle. And with this cap, we can see, well, sort of looks a bit like that, but no, it was sort of more like that. You can see basically it's a big magnet. It causes depolarization of cells in the primary motor cortex, and that produces an evoked potential, which then is measured on the target muscle, measured as this waveform where the MEP amplitude is an indication of excitatory influences for the motor cortex, and the silent period duration is a measure of the inhibitory influences there. And so we looked at other researchers. There are only a few that had looked at this with manual therapy. Dishman, looking at in chiropractic spinal manipulation, found transient increases. Clark looked at low back pain patients and but didn't find alterations. And there was some, arguably in both cases, they weren't using, say, standard protocols for measurement of these. So we did a study initially on high velocity, where looking at both H reflexes and the MEPs, asymptomatic subjects, really just like a pilot study, but looking at the effect of a specific high velocity joint on the low back, comparing it to a control, a prepositioning control, using a standard methodology with the H reflex, and a standard methodology using this double cone coil, where we made sure that we did tested the maximal voluntary contraction of the gastrocnemius, because this was important to bring up the measurements for the evoked potentials. So they had to be contracting at exactly 10% of maximal voluntary contraction in order to enhance these recordings. And we sort of just had a crossover trial. And what we did find is both of them were significantly reduced immediately, suggesting that high velocity reduces the excitability of both the neurons in the motor cortex and the motor neurons in the spinal cord itself. And later on, we did another one using a muscle energy technique and found very similar things there as well, which I thought was interesting. Another way of trying to investigate, do we influence motor output with techniques? However, there are big limitations of these studies. These ones were done with healthy asymptomatic participants, small sample sizes. It was a predetermined manipulative technique. It wasn't addressing a particular dysfunction, and we're only looking at the immediate effects, not the long-term effects. So the clinical implications are speculative, but it's an area I think worthy of further investigation. And correlating them to clinical outcome measures, how long do they last, and so on. So it sort of brings almost to a close my talk of my investigation in this particular area. What I was finding is that definitely the tissues that we detect using palpation are objectively more sensitive to pain, even without a report of tenderness. There's something that we're palpating that's going on. We can identify tissues that are sensitive to the patient without necessarily certainly not needing to be guided by the report of pain there. We palpate them first. We know from these studies and others that OMT might influence motor processing, and there are other studies about sensory processing, but it seems this is complex. It's not having some simple, immediate reflex relaxation of the muscles, and we're not. It's not clear that the things that we're palpating are related to abnormal motor activity in the first place. So the indwelling EMG recordings, it's problematic. I know other studies I've seen report indwelling fine wire in functional tasks. I don't know how they do it, because we tried a few times, and every time we lost channels. The wires moved, and it just represents these very deep pressures going on in these deep stabilizing muscles. Others appear to have reported EMG activity from deep muscles, but I would love to see how they do it, because it wasn't our experience. So it's probably not fruitful to further investigate with these particular methods. An area that I think is of great interest, well, if it's not muscle activity that we're palpating, but these areas definitely feel different and they're sensitive, it may be more related to pain mechanisms, local pain mechanisms, and potentially, it's speculative, but potentially things like neurogenic inflammation. We know that activated nociceptors have a secretory role. They dump inflammatory cytokines into the tissue and promote inflammation, even in the absence of any tissue damage. And it could be that what we're palpating is a result of this neurogenic inflammation, because we can palpate these things in more chronic people with chronic pain as well as more acute pain. And it would be interesting to investigate the tissue millennia of around this area, perhaps using things like microdialysis, that techniques that people like Jay Shah have used for examining trigger point, the tissue fluids around trigger points. And just another possible area that might bring light on what is it we're palpating. Thank you very much for your attention, and I'd be very happy to take questions.
All right. Well, thank you very much. And before we hop into questions, I just want to remind attendees that if you would like to speak during the discussion section, please raise your hand emoji, which is located at the bottom of your screen under the reactions menu. When contributing to the discussion, please limit microphone time to just a few minutes, as we only have a few minutes of discussion time available today. And then the moderators would be happy to read any questions or comments that you would prefer to type into the chat. As we do only have a few times for discussion live, remember that as this will be posted on YouTube, any questions you might have can always be posted there, and we can continue any discussion on the YouTube channel. So I hand it over to Dr. Brooks.
Thank you, Gary, for a superb presentation and your many, many years of hard work. Our whole profession is indebted to you. My concern is that your efforts to understand the pathophysiology may be diluted. In the United States, we have an ice cream, or we used to have an ice cream parlor that advertised 37 flavors. And I'm concerned that there's some assumptions made about what we classically call tissue texture changes, and that, in fact, there are many different types. And certainly classically, we discriminate between acute and chronic. And even in my personal experience, I think that there might be times when muscles are hypotonic, both in certain acute phases and in chronic phases. As you identified, there are issues about fluid flow, and there's just a whole raft of things that we classically have described as just grossly a difference between acute and chronic. And I think that if we could find a way, in a valid and reliable way, which is very, very challenging, to come up with some more categories, then your exploration of pathophysiology might be more robust, because pathophysiology of chocolate might be different than vanilla, might be different than strawberry. So thank you again.
Oh, look, thank you, William. Nice to see you again. I totally concur with what you're saying. It's look, it's a challenge. Firstly, because the studies that have tried to investigate the reliability of tissue texture change haven't been very successful. We tend to not agree with each other, and it could be because it's a complex phenomena, and we, there could be different flavors of change, and we don't quite have the language yet to describe those accurately to agree with each other. If you look in the literature, there's, tight, boggy, doughy, all these sort of descriptors, which could mean different things to different people. It would be great to try to standardize that. And I totally agree that it could be, we're looking at different things in different cases. But areas for future investigation, I think.
You go ahead, Dr. Brooks. We probably have time for one more question.
Yeah, so you mentioned briefly that there were changes when people, I think, moved or something. But the other thing that needs to be taken into consideration is that not only demotions of bones, but so-called soft tissue texture changes may change in different mechanical contexts, just postural contexts. So I think we need to be very, very conscious of specifying those in any kind of investigations. And apples just, they all might be apples, but they're Gala and Pink Lady, etc. So mechanical contexts, I think, are very important to specify.
Well, yes, and I had wished to try to quantify, the muscle activity in different functional tasks, but our readings weren't reliable. The actual electrodes were moving, within the tissue itself due to the forces exerted, deep, within the fascicles and so on. So we weren't able to study it in a reliable fashion because it was so changeable, unfortunately. And again, maybe there are other methods to do this. Certainly surface electrodes are a good way of doing it, but it doesn't give you information about the deeper tissues.
Well, unfortunately, our live discussion time is up for today. Don't forget that this webinar recording will be placed on the DO-Touch.NET YouTube channel, and we can continue this discussion there. Watch your email for an announcement when that recording is available. And Dr. Fryer, we thank you very much again for your presentation today. And our next episode of Let's Talk About OMM Research will be a journal club, and that will be on November 21st. With Dr. Francois Lalonde. And the article that will be presented on will be International Overview of Somatic Dysfunction Assessment and Treatment in Osteopathic Research. And we hope to see you all then.
Thank you.
Great.
Bye,
Thanks very much.
everybody. Thank
Thank you
you.
very much.